Welcome to today's webinar. The topic for today is how activity-dependent neuroplasticity principles drive therapeutic change and lead to improved functional outcomes in central nervous system disorders. My name is Megan Klein, and I will facilitate our meeting. Please note, the information contained in this presentation is intended to provide general information but not advice about certain regulations and initiatives. This is not intended as legal or other advice, and each situation may vary depending on the particular facts and circumstances. You should not act upon this information without first consulting qualified legal counsel. Today's webinar will be presented by David Wilcox, who most recently serves as the clinical educator for Biodex Medical Systems, where he executes unique educational approaches to optimize the use and sales of various products. David has built cost-effective solutions to provide exemplary training for therapists and their patients, focusing on those with neurologic and orthopedic pathologies. He currently serves as the subject matter expert for sales teams and senior executive clients while launching a new product to improve interdepartmental communication. David has co-authored several books and chapters in the past decade, highlighting his expertise in the field of clinical and therapeutic practices. And now, please welcome Dave Wilcox.
Hi, everybody. Welcome to today's webinar. We're going to talk about some of these activity-dependent principles that drive neuroplasticity, that drive the changes in the brain that occur following a central nervous system disorder, whether it's traumatic brain injury, stroke, Parkinson's, so on and so forth. Of course, we have to tie that into some of the research too. But even with the research, I'm going to try to pepper in some of my own clinical expertise. Megan, thanks for that great introduction. I myself have over 20 years of experience as a therapist. I'm a neurologically trained OT. Back in Philadelphia, and I've had about 20 years working at a rehab hospital called Moss Rehab on their neuro unit. So I've been able to take a lot of these concepts and principles and research and evidence and really pepper this into the treatment of my clients. So that's something I want to share with you guys today. We're going to veer off and talk about some of the common therapy practices that we all might do in the clinic that might not necessarily induce those changes, those central nervous system changes. I know that I'm guilty of it, so that's something that I can talk about because, it's something that I've done in the past and continue to do at times. It's challenging. There's a lot of challenges as why it's hard to carry over some of these important principles and concepts. We'll just touch upon some of the non-technology and technology-based solutions that can help support us in those, that help carry over to some of those principles. And then why are outcome-based tests important? Well, because, we need to be able to track, those changes. Let's talk about those 10 principles. All right, so these are in the evidence. They're relatively new. If you think about therapy over the course of the last few decades, most of the research has actually been done. I found in my experience of looking at the research, late 90s, but most of this has been in the 2000s. The evidence has really come out, and the research has really come out these 10 principles. Use it or lose it. Use it and improve it. We're going to skip over the next 3. Time matters. So this early training after a stroke, traumatic brain injury, and other neurologic disorders, got to get them in early to really influence change of that brain. Salience, or the quality of therapy, obviously matters. Age matters, so we know that younger customers, younger clients, we're going to be able to drive neuroplasticity a little bit better in the younger clientele. Transference and interference. But the 3 that we're going to focus in on today, and pretty much all we have time for, are going to be the 3 right in the middle: intensity, task specificity, or task-oriented training, and of course talking about repetition. So these are some principles you guys might be already practicing, but I find that for me, it's always it's good to come back and revisit these as a foundation for not only with central nervous system disorders, but with orthopedic conditions as well. So why these three principles? Well, these are the top three influencers that really drive the changes in their neuromuscular and cardiopulmonary systems. All right, these three influences really address these underlying improvements, these underlying impairments that drive the motor system. And it really ties into some of these training principles, these exercise principles that we do now, which I found very interesting. And this is why I added it, because I think about, when I'm treating patients, and specifically for this presentation, central nervous system disorders, why should it be different than the way that I train? So like if I'm training for a triathlon, or if I'm training for a a marathon, the only way that I'm going to get better at it is if I do it frequently, repetitiously. Task, I have to actually practice the task, and I have to be intense about it. And these are the only ways that my neuromuscular system is going to be able to adapt, so I can eventually be able to do that marathon. So I got thinking when I was reading this, I'm like, well, why is it really different for our patients? If this is the way our neuromuscular system is able to be trained, then maybe we should kind of carry these same principles over to a certain degree with our patients. So let's just dive into the first one, which is intensity. So this is basically just the amount of energy that's expended, so high energy that's expended. And you're going to see it in the research that it's dosage, it's kind of interchanged with the word dosage, but it's ill-defined. Some of the research that I've done and some of the reading, it's been defined as hours spent in therapy, the duration of the sessions, and the training amount. Okay, but it really never really talks about that intensity. And this is where we kind of go into the gold standard of training. And this is a little bit more objective. This is a little bit more direct, but really looking at heart rate training, as well as using a scale like the Borg rating of perceived exertion, that we're able to measure objectively the intensity of how we're able to when we're working with our patients. Okay, so these are just some things. A colleague of mine, Kurt Jackson, out of University of Dayton, he's a big fan of calculating heart rate training and using heart rate training to really measure the intensity and how it's influenced on our patients. And really, intensity it's relative. Our intensity as healthy individuals is going to be different than our patients, but we can still utilize these measurements. I'm not going to go through them specifically, but the calculating your heart rate zone is over to your left, and to your right. I have to apologize. It said this perceived exertion scale. I just realized today it's not the Borg, but the Borg is actually a scale from 6 to 20, and this goes from 0 to 10, but you guys can kind of get the idea. But, well, how does intensity increase performance? Well, likely because it increases neuromuscular activity, in the brain, central nervous system, peripheral nervous systems, our muscles. It also has an influence on what's called blood-derived neurotropic factor. Okay, so basically this is a protein for the brain. Most simply explained, a fertilizer. Someone explained to me that it's kind of like a fertilizer for the brain. It's a protein, and it has to do with the neurons and the synapses. And when that increases, it really influences movement and learning. And the intensity also it increases the muscular demands as well. Of course, there are some drawbacks. There's overtraining, there's increased spasticity. However, in some recent studies and some courses that I took, they noticed that the spasticity increased, but it was actually short-term. It actually decreased over long-term. Then we have to be, cardiovascular concerns like blood pressure, autonomic responses. We do have to use our clinical judgment. As we think about this intensity, as important as it is, and probably the most important one, we do have to use our clinical judgment and think about some of the things and how it's impacting our patients. Orthopedic concerns, knee hyperextension, ankle eversion, and eversion. And you know what, there's bracing to protect the joints, but I think of myself as a therapist, and that's why I'm when I'm working with my patients, I will use my hands to try to prevent hyperextension or that eversion and inversion. So, we can kind of, outside of the joints, outside of the bracing, we can utilize our own facilitatory techniques. Okay. Lots of research out there. So you're going to see names like Hornby, Kitago, and Krakauer. All right. Yeah, it's supported all over the place, and there's a lot of the research out there really supports the importance of intensity. The second one down, there's evidence, level 1, level 2 evidence that clinicians should use moderate to high intensity training interventions to improve walking speed. So this is a physical therapist that addresses walking. Where Krakauer and other research looked at upper extremities. So it's not just with lower extremities and walking, but we're talking about upper extremity as well for our OTs as well that are listening in this presentation. Okay. So just sticking with Hornby, he suggests that, there's a lot of emerging information out there, a lot of data that is showing that increasing the intensity and the variability, there's your task-oriented and specificity of stepping practice is really critical, but these strategies really are not supported in a traditional rehab setting. So in one of his studies, he looks at a control group and an experimental group. He did low intensity training with the control group at 30 to 40% max heart rate. So that kind of goes back to what we were looking at before. Where the experimental group with a high intensity training at 70, 80%. Obviously, the conclusion was that the high intensity stepping walking training resulted in greater improvements in walking, not just walking ability, but better symmetry. So I think again, I'm going to pepper some clinical stuff in here, and ever since I've done some research and been doing a lot of reading and just developing these presentations, when I'm in the clinic, which is a couple times a month, this is the direction that I've been able to go into. It really gives me a good base as to where is my patient and how intense is this for my patient. So I do a lot of heart rate training, I do a lot of pulse ox monitoring, blood pressure, and this is something I'm always keeping constant as I'm working with my patient. And of course, I'm checking with the physician to make sure that everything's okay. Okay. The BDNF, this is by a gentleman named Mark Hirsch. He's one of the leading researchers in BDNF. And he did a first meta-analysis that looked at the influence of the intensity of exercise direct impact on the BDNF. And what they found is that with increased exercise, you have the increased BDNF, and then of course, they give a Berg balance scale and a MOCA, and both scores were able to increase. So this is the importance of bringing in these evidence-based tests to kind of really get a baseline of where you're at. And then what does that intensity, how does that really influence the scores of these tests? So I quoted this is the beginning of what I believe is some really exciting work. So there's a lot of BNF work being done out there, especially with Parkinson's disease as well. Next category is task specificity. All right, this is an activity that really focuses around the accomplishment of a functional task. So it's not sitting down and doing TheraBand, it's not sitting down and doing bicep curls. It's actually engaging in a functional activity that requires multiple movement patterns, multiple joints, as these are some of the underlying concepts. Skill acquisition under this occur with a combination of movement patterns using numerous joints and muscles. Okay, and then another underlying concept is that the central nervous system is highly interactive and movements are complex. So if that's the case, then that's how we should be training them under the task specificity. Okay, a lot of research out there. Just wanted to bring this in by Hornby. Everything has to be backed up by research. So yeah, there's a lot of information out there. If you basically can go to Google Scholar and really look at task specificity, intensity, repetition, and so on and so forth, and get a lot of information. Okay. All right, repetition. So here's the third category. So obviously more practice, early practice equals more improvement. Okay, so early training appears care is crucial to promoting recovery of an impairment after brain organization, in brain organization after the central nervous system injury. So we've got to get them in early, and we got to do more of it, okay? Because repetition, it builds that neural circuitry, you know, in the absence of training. So like that's how we're going to be able to influence that carryover. The more that we're able to get them to repeat and to get them engaged, you know, that's what it's really about. You know, once they're out of rehab and once they're out of therapy, it's about being able to give them the skills to be able to carry that over as independent as possible while they're in the home, without too much burden on the caregiver. But task practice alone, in the absence of repetition, does not drive plasticity. You know, so you know that I think about like a person like putting on like a toothpaste onto a toothbrush. You know, so not just one time, like I would do like in a normal ADL setting. But maybe if I bring that patient back, maybe I'll have them practice that numerous times over and over. So the task specificity, in addition to the repetition, and intensity, because there's an intensity component to that too, is going to drive that neuroplasticity. Well, what is the significant amount of practice required to create that change? Well, there's a lot of conflicting research, but we do know that, you know, 3 sets of 10 isn't going to drive neuroplasticity. 4 sets of 10 is not going to drive neuroplasticity. You know, and I'm guilty of this, you know, where you give the person a TheraBand or you have them practice a ball activity or whatever. Like, yeah, let's do that 3 sets of 10, 4 sets of 10. When really, indeed, the research points to like 300 to 400 repetitions, you know. And one researcher that really supports this is this Krakauer, John Krakauer out of, I don't know if he's out of Hopkins, but he's done a lot of animal studies, or regular studies on human beings that, you know, this is where we're talking about, is the 300 to 400 repetitions. It's like, yeah, right. It's really challenging to do. I understand that. And some of that supportive research, just one to point out, the feasibility of high repetition task-specific training. So this, instead of like the lower extremity, let's just switch over to the upper extremity, where the study looked at 60 minutes a day, 4 days a week of OT. They incorporated 300 repetitions of a task relating to an ADL. So again, it goes back to what we talked about a little earlier, which is the prepping the toothpaste, and then noticed significant improvements in functional outcome measures. So there's that task specificity and that repetition. Last one, with patient cooperation and intense repetition, cortical reorganization can be facilitated. And this has been looked at with you know, the transcranial magnetic stimulation and functional MRI. So this is what they're looking at to really see how this intense repetition influences function. So let's switch gears here a little bit. I'm just trying to do a time check. Let's just talk about some of the common therapy practices that make it very challenging. You know, I want to be realistic here. It's like, how realistic is it to do 300 to 400 repetitions in a 45-minute session when you have so many other things to do? It's hard. It's, you know, I struggle with it every time that I'm in the clinic. I know from the research that these repetitions are in intensity, and the task specificity is so important, but sometimes our environment and the way that our jobs are doesn't really support that. So I do want to recognize that. Again, some of the research, Lang monitored some inpatient stroke rehab settings, and noticed that task-specific upper extremity movements happen less than 50% of the sessions, with an average of 32 repetitions, which is what 10, very, very minimal, the fraction of 300, 400 that's required. Okay. Despite acknowledgement of these principles, the majority of time is still spent in a wheelchair and in a bed. Observational study by Kauer, he observed and recognized that physical therapists overestimate the time patients were active in therapy. Interesting. So I went to this really cool course at the ACRM conference. It's this really cool conference that happens every year. I really highly recommend it if you guys haven't been to it already. But it's rehab medicine. It's a rehab medicine conference that really bridges the current evidence and clinical practice, and it really bridges the two, and they do a really nice job of it. I love this conference, and like I said, I would highly recommend to put it on your docket if if the next time we're able to get together in a group setting, whether it's 2021 or 2022, I don't know what it's going to be. But this one particular talk that I went to, it was one of my favorites, and it was, again, George Hornby, and it was called Removing the Gloves in Neurologic Rehabilitation. And these are some of the quotes that he came out with of like, well, these are some of the things that we might tell ourselves in the clinic. And I want to personalize this because these quotes I've totally told myself at some point in my career, whether it's early in my career or later in my career. But as we were kind of going through this presentation, I was like kind of snickering a little bit. I'm like, oh my God, I totally told myself that a few times at some point in my career. Some of the quotes that he pointed out, I don't want to hurt my patient. I said that to myself. I don't have 3 people, or I don't have the equipment to be able to drive that neuroplasticity. Practicing abnormal movement patterns reinforces abnormal movements. Interesting, right? Perfect practice makes perfect. And the patients might not be ready for walking. Okay, so again, everything that I've seen here is like, oh God, yeah, I definitely have told that to myself at some point. Okay. Let's look at that first one. I don't want to hurt my patient. Well, to tell you the truth, there's limited and insignificant evidence of increased risk of cardiovascular events. If you're worried about it, well, obviously we're going to get a cardiology consult, ECG testing if there are concerns. But you know what? Ever since I kind of started thinking about this stuff, I have a pulse ox with me. I monitor these 3 things constantly, as I am working with my patients. And this is how I'm able to really gauge how to push my patient. Breathing as needed to protect the joints, but also facilitatory techniques and ambition techniques to try to utilize your hands to prevent that knee hyperextension, to try to get that hip extension, maybe a hand down at the ankle so it doesn't, so things don't happen down there. I don't have 3 people or equipment to do this. Well, we have high-tech stuff, and then we have lower-tech stuff. So for example, we have body weight support systems like the Biodex Next Step. This is, obviously I work for Biodex, but I also use this as a clinician. So what's unique about my position is that not only do I know our equipment, but I actually go into facilities and I actually work with patients, with the clinicians on our products, which is really fun. But this allows you to kind of get up to that next step without requiring that extra aid or that extra therapist to get them up and to do things. And so these are the lower end things are very, very successful. I know that clinicians out there are very happy with the Next Step and the Light Gate, but they also have higher stuff too, the Locomat as well as other robotics as well. And then interestingly enough here, 2 to 3 therapists are not always needed in multiple studies. Again, pepper it with my own experience. In the beginning, in the entry-level clinician days, and I started off, my very first job at Moss was working on a traumatic brain injury unit, and I worked with really low-level patients. And so we always co-treated with the PT, the OT, and then usually we had an aide around us because typically our patients were dependent, max assist, maybe mod assist if we were lucky. But as I gained more confidence, as I kind of gained more experience with that and learned my own body mechanics and how to facilitate the patient, where in the beginning I was able to do it, I needed 2 to 3 people. I can go in now and work with dependent patients and as I'm 20 years older now, but ironically I can do it with one person. I can do it by myself a good portion of the time. That's if they don't have pusher syndrome and they're not retropulsing where I can't get them. But if they're dependent and they don't have any sitting balance, there are certain things that I can do and facilitate patients that I can utilize just one person. Practicing abnormal patterns reinforces abnormal movements. Interestingly enough, there's no evidence of sustained spastic abnormalities. High-intensity activities result in temporary spastic abnormalities in numerous studies. So in this study I saw, in this video of this presentation that I went to, George Hornby was I think it's going back to September now or October, but he was working with someone and they were doing some really high intensity walking, and there was some spasticity going on, a lot of high tone, but like it changed with time. Like you could see the progression as far as the patient, and they just kept on pushing through that spasticity, pushing through that high tone, and there were definitely visible changes with that intensity. Perfect practice makes perfect. This was a hard one for me because I was in the early 2000s, so there was a lot of NDT training back then. I got NDT trained on multiple levels, and it really was about perfect practice. So this was just interesting to me because, you know, Hornby did look at studies, various studies that looked at training with focus on facilitating normal kinematics versus non-facilitation, and he didn't notice a lot of significant difference. Now, that was lower extremity. Perhaps it's a little bit different with upper extremity, you know, especially when you have a lot of stuff going on. But again, when I'm in the clinic and I'm practicing, I definitely think about this stuff in the back of my head, and I kind of play with both concepts of both schools of thought, you know, with the NDT and really trying to practice the perfect movement, but now considering what I've been able to learn through this information. Patients might not be ready for walking. This drives me crazy, you know, in the clinic. We got to get them up on the first day. You know, I think of this as if this was my grandfather, if this is my grandmother, you know what, like we got to get them up. We got to get them up. And there's a lot of evidence that this early training, even from day one, does indeed impact that recovery. And it kind of goes back to, let's go back to this slide, sorry. This graph up in the upper right-hand corner, and I'm going to point to an arrow, but look at this. Look at this curve right there. This is where the most improvement's going to happen. So we've got to take advantage of that from day one. Common therapy practice again. So why are we falling short? Well, first of all, when we look at intensity, there really is no smoking gun. There's no protocol. There's no true prescription as to look at, like, when you're looking in the research, a lot of the research is looking at, like, amount of time in therapy, and the duration. That doesn't really give you a prescription or a protocol of, like, what intensity is, you know? So this is where we kind of come back to the gold standard, you know, that Rehab Institute of Chicago, now known as Ability Ryan, you know, they're using that gold standard. You know, they're using intensity and using heart rate training, and they're training people at 60 to 85% of their heart rate max. You know, 14 to 17 of the RPE, the perceived exertion. Okay, their task specificity, repetition, treadmill and overground training, multiple directions, obstacles, stairs, uneven compliance surfaces, curbs. They're really challenging the patients and really oh, here we go. Okay. Well, you guys might agree with this, some of you. Maybe I know, like for me, in some of the clinics that I've been in, that the rehab gyms, they just weren't designed well enough to support this high intensity, high repetitive task training. There are financial challenges. We know that there's lack of caregiver support for any type of carryover in the room or at home. And of course, there's factors specific to the patient, such as motivation. Not just motivation, that's just but there's cognitive challenges as well. I mean, there's multiple challenges. Insurance companies kind of push us along. You know, a patient comes in and, you know, they come in with a specific diagnosis, and we got 3 weeks with them. That's all we got with them. You know, so that can cloud, that puts us under a good deal of stress, you know, because, you know, we can easily really overlook these neuroplasticity principles because we've got to get them as independent as possible. And sometimes getting them independent is teaching them compensatory strategies, allowing that learned non-use to occur. So if they're a hemiplegic patient, or not hemiplegic, then we might not encourage them to use their affected side. Like, you know what, let's get you as independent as possible with upper body dressing, just using the one hand, you know, because we only have a couple weeks with you. And that really takes away our ability to really focus in on these principles of high repetition and intensity. It's not easy. I know it's not. Well, what are some things that you can do? Well, there are some suggestions out there. I learned this motor activity log tracking, where you write things down. I think this is great for homework. I also think it's great, like working in rehab, I actually did the numbers. I tell patients, listen, like as a therapist, I'm going to do the hard stuff. You know, when you're in OT for an hour and a half a day, we're going to do the hard stuff. I'm going to give you some homework assignments. If they're cognitively intact, you know, so it's patient specific. And I'll bring the family members in, and I said, I'm going to give you homework, because if you consider 8 hours in the wheelchair, say 8 hours sleeping, you're at meals 3 hours a day, then you're in rehab for 3.5 hours a day, kind of gives you about 8 to 9 hours of downtime. I said, you know what, when you're watching TV, maybe during a commercial, maybe you want to practice with a pencil and write your name down if it's hemiparesis, or give them specific activities that they can do on their own, the little things, because it reinforces that repetition. It reinforces that task specificity that, you know, we are trying to encourage them to do all the time. Rehab just doesn't have to happen in the rehab gym. Our body needs it all the time. So I really do work with the patients to encourage them to do something, you know, in their room. And it's funny, at the end of the day, I will walk past and I will see patients pick up a pencil, for example, if I taught them that skill. I said, you know what, I want you to write your name. Your homework assignment is to write your name 100 times. I don't care what it looks like. I want you, but the point of the matter is I want a pencil in your hand, and I want you to do it the best that you can. I don't know, I just try to be creative outside of this, you know, the rehab gym that I work in. Obviously, there's emerging technologies to try to help us promote this repetition and task specificity and intensity. And we can go on at the low end, and then we can go on the high end. But there's robotics out there, there's virtual reality, and there's dynamometers. Like we have a dynamometer with upper extremity function and the legs as well. But, you know, if you're trying to make a case of why you want to get a $10,000, $20,000 piece of equipment, well, you know what, this makes a pretty good case. You know, if you're trying to really reinforce repetition and task specificity and intensity, beyond what we can do with our human hands as therapists, well, there's a lot of cool technology that can really help us out with that. And we live in a country that can really help us out with that. And I've had the opportunity to do it, and it really does make a difference. All right, what are some other ways that we can promote repetition and task specificity and intensity? Well, there's telehealth, remote therapy to maximize carryover in the home, providing self-directed practice opportunities for our patients. So self-directed, yeah, I mean, I've set up my sessions where to kind of put the opportunity in my patient's hand to kind of give them the autonomy to direct appropriate group and circuit activities. A new business model, which I read is rehab gyms. You know, so I know that I always thought about, like, it would be so cool to start a rehab gym just for Parkinson's patients. You know, where Parkinson's patients, it's going to be a pandemic. You know, in the next few years anyway, it's going to explode. And we know that with intensive exercise that we can really delay the Parkinson's process. So I always felt like I would love to be able to open up not just a Parkinson's gym, but a central nervous system disorder gym where I had that experience and work with physical therapist cohorts of mine to really maximize these three concepts. There are online resources for us. I don't know if you guys know of MedBridge, but that kind of seems to be the go-to for CEs these days. It's a little bit on the expensive side, but they offer some really cool courses like this neurologic OT, upper extremity motor rehab certificate program. I just kind of looked it up, and it looked kind of cool. I mean, I'm not in the clinic anymore, so it's not for me. But there are more resources out there that can really help us gain more information and really kind of bring our skills to that next level, so we can ensure that we're carrying through these principles. Sorry, I'm losing my voice there. Time check. All right, so let's just veer off again and talk about some of the non-technology and technology-based solutions. Okay, so let's talk about building the base. All right, so we're trying to still make it functional, but we can look at strength training, we can look at range of motion, and these are just some particulars that we can look at. focus on anti-gravity muscles and postural extensors, making it as functional whenever possible, focusing on scapular retractors, extensors, flexors, ankle inversion, and eversion. Range of motion and strengthening. Again, this is from some physical therapy colleagues of mine. This is what they do and some of the research in here. You can focus in on ankle, great toe extension, hip and knee extension, and with the upper extremity, shoulder external rotation, flexion and abduction. And that makes sense because if you get a central nervous system disorder, what's happening is that your internal rotators are so tight and there's so many of them, you go into here because you get the pec major and the pec minor that are pulling that shoulder into internal rotation. So really getting them onto a mat and getting them stretched out and trying to make that as functional as possible. Well, how can we do that? Well, we have different traditional methods. We can be creative on mats and using doorways and chairs and everything else. But they do have on the right-hand side of the screen over here, they have this little rehab gym, and then that's a low-end, low expensive technology, and then you have higher-end technology with isokinetics with the the dynamometer that you can really focus in on as well to really kind of build that muscle. Balance. Well, we're thinking about intensity. Remember that intensity is relative. Like our intensity is not going to be the same as our patients. It's going to be scaled down much more. Key principles. Perform when standing and when possible without upper extremity support. I want to get my patients kind of uncomfortable. I want to keep them safe, but I want to keep them uncomfortable. Alter the sensory system. When my patient begins to master eyes open on a firm surface with their shoes on, I'm not happy. Like we got to alter the vision. I want to turn the head, maybe remove the solid surface, have them practice on the foam pad because you know what? That's what's going to be like at home when they're walking to the bathroom in the middle of the night. They don't have the vision and they have a nice thick carpet that takes away their proprioception, which puts them at fall risk. Challenge their failure. This is interesting because I think this is the nice thing about technology is that, and I'm going to show you a video in a little bit, it's okay to fail. It's okay to fail as long as we're keeping our patients safe. I think that early in my career, I was so worried about the failure because it was a safety issue. Well, there's technology out there, there are devices out there that allow us to really kind of push our patients where they are failing. And I'll show you in a minute a video of how fast neuromuscular system changes when you allow them to kind of discover movements and push them to the point of that failure in a safe environment. Include static, dynamic, and reactive balance. Interesting, reactive balance. I'm never really focusing on, never worried about patients like looking at something and then like falling, like not being able to move around it or falling over it. I worry about the reactive situations. And in order to be able to train reactivity, in order to get better at reactive balance and reactive postural control, you have to train it. That's the only way it's going to come back. It's got to be intense, it's got to be repetitious, and it's not going to come back if you put them on a leg extension machine. All right, reactive control happens with reactive training. Make it progressive, proven sufficient dosage with balance is greater than 50 hours. Again, there's that number again. It's a little bit lower on this time, and should have a regular tune-up. So, all right. These are just different balance interventions. I look at balance as static. There's anticipatory, and then there's an anticipatory no body transit and with body transit. So you guys can take a look at this. I'm not going to go over it. It's something that you guys probably practice already. But the point of the matter and the point of this presentation is that, how am I thinking about intensity? How am I thinking about repetition and task specificity? That's where I'm with this. So it's like I know what my activities are, but how can I really try to bring these principles in as much as I can to the best of my capability? Okay, so basic activities over here that we can work on, that intensity, that task specificity, and that challenge. This is a patient that I was working with a physical therapist over here on the right-hand side. And this is the biofeedback. And this was a man that was, he's got, I think, diabetic neuropathy, and he was retropulsing anytime that he transferred. So that's what he required, a mod assist with a sit to stand and a stand to sit. He could not, he'd always fall backwards. He could not figure out how to put his center of gravity over his base of support. So we used to detect the technology to be able to teach him. So I'll just play this video real quick. I'll turn the sound down a little bit. But he's sitting on the edge of a mat. He's got the visual biofeedback. And remember, think about repetition, think about task specificity, think about intensity, right? So they're talking, they're educating, using the visual biofeedback. And basically the visual biofeedback is teaching them how to keep a center of mass over his base of support as he's going from a sit to a stand position and so forth. So granted, at the beginning, that was a mod assist. And he's already halfway down, and he doesn't even require any type of intervention. So he's learning how to do that sit to stand. This is intense for him. This is repetition, and it's task specific. Okay, because the goal right here is to try to get him to be as independent as possible with his functional transfers, which includes teaching him how to get a center of mass over his base of support. So his wife, who is half of his size, doesn't have to lift him up off the toilet or out of a car. So it doesn't matter if it's OT or PT, it's still the same thing. So we had a blast during the session, but these are some of the things that I was thinking about. I was going, oh, this is task specific. This is definitely intense. It was definitely intense for him. And we actually continued on with it, and we did about 20 of them. So it was repetition. Here's reactive balance. So again, we got to challenge our patients. That's the only way that we're going to influence this neurologic system. So these are just different ways of being able to challenge our higher level central nervous system disorders or orthopedic disorders, if you want to go that far. Well, how do we do that? Well, we can be creative in doing that because that reactive balance, although that it's scary, it's still really important to train. And it's intense and it's repetitious. This is a video that I did. I just wanted to show you. So what's nice about the technology, I don't need another. Hold on. So I can work on various features of different balance training. I don't think this is the reactive video. Or I could work on walking and stuff like that, but I don't need numerous therapists. It's repetition, intense, so on and so forth. Let's go to the next video. I don't want to show that. Task-specific gain interventions. Again, minimize upper extremity support. You're just basically trying to find the biggest challenge for the patient, whether you're an OT or a PT. What's going to challenge that patient? What's going to make it intense? What's going to make it repetitions? Because that's how we're going to influence that neurologic system. In other words, for me, when I really started thinking about these principles, and I look at dressing sticks, I look at reachers, you know what? No, not anymore. Not unless they have like hip precautions. I don't go that direction anymore if I can. I want them to be challenged as much as possible. I can always bring in the assistive devices a little bit later on, but like if they're a stroke patient and they can't reach their feet, I'm not going to give them a dressing aid right away. Like we're going to work on dynamic balance. We're going to work on leaning forward, and you're going to work on that trunk extension and that flexion, and you're going to learn how to do it without the devices. Task-specific gain intervention. Sorry, do a time check. Okay. Here's some technology-based solutions using gates. Okay, this one might be normally what might we see right here? We might see this gentleman using maybe a quad cane or a hemi walker. Okay. But we're using this technology to teach him how to walk forward, backward, sideways, just with some therapeutic intervention. That's another thing I do as a clinician. I live in Philadelphia, so a lot of people live in row homes. So what happens in a row home is that when they get home and they've been taught how to use the walker, what happens to that walker in a tight area? It becomes really annoying. So what do? They push it off to the side. So most of the time I want to teach my patients how to walk functionally in the kitchen without an assistive device if I can, utilizing the countertops, because that's the realistic situation. If you're going to put your walker or cane off to the side, you know what? We're going to learn how to do it without it. So this is what I like about the technology, is that it allows you to take away and really challenge that neuromuscular system. I think this is the one of reactive balance. Oh, so this is reactive balance training. Again, what I love about the technology, and again, it doesn't have to, we're going to go back into this, it doesn't have to go, you know, this is our next step. I mean, there are other products out there that we can do, you know, but we don't have to utilize other therapists, other aides, and we can really challenge the patient's dynamic balance and push them to the point of a little bit of failure, you know. So when we're doing this reactive balance situation and we're training reactive balance in the posterior direction, you know, tell me if you would ever do this in the parallel bars. Probably not. But with the technology, you know what, we can make this happen. And it's really important because we've got to train that reactive control, and that's task specific, that's repetitious, and that's intense for the patient. It's amazing to see how fast neurologic systems change when you're doing stuff like that. It doesn't matter if you're an OT or PT, because this could be a patient slipping out of a tub. Here's something for you. You know, a towel underneath their feet. You know, that's very functional. That's very OT, very PT. Oops, hold on. Okay, this is my friend and colleague Kurt Jackson. Just wanted to show you this. Now look at reactive balance, and then look at the technology and look what he's doing. I'll turn the volume down a little bit. So I mean, I don't know what he is. It's an older video, but it's obviously a stroke patient. But you know, he's pushing him to the point of like this is his third kick. Look how fast his neurologic system changed already. Look how he was able, with that reactive, like from the first kick to this kick, how much more control he has. That's how fast the neurologic system changes. And you notice how he kind of started falling backwards. I want that to happen. You know, when he's protected in this technology, it's lower base technology. This is actually our free step. But it could be other products, like just the next step and other products, but really pushing them to the point of that challenge. Because if it doesn't happen here, and they have to learn it, it's going to happen at home. So I like to look at it as like, well, let's practice it in therapy, and let's train your neurologic system. Let's make this as intense as possible. Let's make it repetitious. Let's make this, you know, task specific, because you know what? This is going to happen at home, and your body is going to have to recognize it and learn how to react. So kind of cool. This is something I incorporate. Everybody looks at me like I have 10 heads when I'm practicing now, but they're safe. He's not going to fall on the floor. This is something that my colleague did with reactive stepping. And so he's got him on he's got this patient on a treadmill. Now I just want to show you something what he's doing to really challenge this patient. This is going to be your higher level central nervous system disorder patient. But just watch. Puts a styrofoam on. Now she's got to walk over it. Okay, this is going to be like negotiating, changing your body when you're going to be doing a curb. The point of the matter is that he's just not walking with her. You know, he's trying to find out what's going to really challenge her so she can learn how to maneuver her own body and her own system. Okay. Just some upper extremity interventions here. Movement against gravity, incorporate shoulder external rotation, bimanual movements, weight bearing, reaching and manipulation through goal activity, task-specific activities. Okay, these are just different ways of how we can promote that upper extremity movement. There's a lot of stuff out there. Maybe some of you guys already have it. Low-base technology, low-cost technology, high-cost technology, and everything in between. Untraditional. Okay. Last here. Okay, you know, what are the importance of outcome based measures? Well, we need a starting point and an end point. You know, how are we going to measure, you know, what we're doing? So I don't know what some of the tests are that you guys use out there. I'm not privy to them as much. I do have a slide in a little bit that kind of points that out. But, why measure? We can predict fall risk, predict discharge status, assess and predict response to treatment, motivate the patient, and obviously get paid. Here's that stepping practice. So, like, if we're going to, again, go back to intensity, repetition, how are we going to be able to measure that? Well, this is pre and post, so using the Berg, using various studies to really kind of help us gauge where that patient is after pre and post treatment. And obviously, if you get a certain score, then this is going to help us determine where that patient could go. Okay. So outcome-based tests. I mean, probably all of us at some point have used the FIM 1, 2, 3, 4, 5, 6, 7. There's the tug, the gait speed, 5 reps at the stand, 2-minute walk test, Berg. We have a couple great outcome-based measures on our products, the Bounce and the Gait Trainer 3, high-functioning FIM, tug, gait speed, same thing. And then over here, just specifically looking at kind of for our OT friends out there, looking at the Fugl-Meyer and Wolf motor function test is a lot of like when I was looking at pre and post tests with repetition and then intensity, I saw a lot of Fugl-Meyer and Wolf motor function tests out there as the test indicators. And then here are just some of the references if you guys are interested. That's kind of taking us up to that hour. All right, Megan, I'm all set.
When you were talking about the idea of repetition, when you mean repetition, do you repeat to fatigue at that point?
Oh yeah, I do within safe limits. I mean, if they're like you gotta use your clinical judgment. Like if I do though. I do within the safe limits. I do. Yes. I find out like how you feeling, how you doing, heart rate's good, pulse ox is good, blood pressure's good. I'm getting tired. Good. 5 more. So I do. I have never, with that approach, I've never dropped a patient. No one's ever fallen on me in 21 years of being a clinician. I've never had to call stat based on my interventions. So there, with that said, there is a degree of clinical judgment, but you know what? I think, and it goes back to what I was talking about earlier. Like, think about your own neurologic system. And when you're training a new skill, you could be learning guitar, which is one of my new things. I run marathons, triathlons, or used to. You know what? Like, I find out where my point is, and then I go to that next level. That's how you get to that next level. So to a watered-down version for patients with central nervous system disorders, I don't think it's any different. I think it's relative, but I definitely think it has to be applied because it applies to all of us.
I love it. So the next one that came in was in regards to a specific study. So the question reads, at one point, there were some studies that were animal-based that indicated the first few days after CVA, general mobility may be plenty while the tissues are recovering and remodeling, and too much too fast equals getting worse. Is this outdated information, or is this something we should still be paying attention to?
I would say when I went to that talk, I would say a lot of that information came in probably like 2017, 2016. I think that's where some of the research studies are. Yeah, you know what? Yeah, you got to kind of take in all that research. What is the year? And I think overall, like, I don't know, like, yeah, I would say those are the later studies, but I know that there are earlier studies that do say that. But with that said, I think you can make a case for both a little bit. If my patient is orthostatic, then I'm not going to push them, or they're getting some other serious. If they're like a T6 or T5 spinal cord patient, they have autonomic dysreflexia, or incomplete injury, yeah, then I think it can still go both ways. But some of the things that I've been coming across has been more of the recent years, pushing the patient.
Got it. Thank you. So we did have a request. Can you repeat the name of that conference that you mentioned and recommended so highly?
Cool. Yeah. It's called the ACRM conference. It's the American something of rehab medicine.
Sure.
And like I said, you know what? I've been to a lot. I've been at the combined sections with my company. I've been to a lot of other conferences. This is my favorite. I love it. It's great. It really talks about like up-to-date research and then how it really can translate into the clinical world, which we know is like there's been huge gaps between the research world and how does that carry over into clinical practice. And this conference is getting bigger and bigger every year. And I've never gone to a conference where there's a course and then you go to that course. You know how like it's like from like 1 to 3:30, and then there's like 30 other courses at that time. I've never been so like, oh my God, I want to go to 10 courses. I don't know which one to go to. I've never been like so like, you know, perplexed as to like what conference to go to. But this ACRM with the George Hornby was because it was about intensity and repetition and task specificity. That was really specific to what I do as a neuro-trained OT. Although a lot of it was physical therapy related, but it's neurologic systems. So it kind of really translates across every joint and every profession.
Sure. So the last question, what was the machine or the specific name of the technology used in the reaction stepping video that you shared?
That was our next step. That was the Biodex next step. So it's NXSTEP, STEP. And so it's an offloading device. Okay, so it's like a light gate. So it was initially designed to offload patients over a treadmill to do body weight support training. But then like I did that video and I came up with like these quick reference clinical guidelines on how to use that product outside of that initial design purpose. So now I've taken the concepts of postural control, which is alignment and a postural stability training, anticipatory balance, and then dynamic gait and reactive balance, those concepts that are in our motor control books, and I applied it to our product. The other one was the Free Step. Free Step is a ceiling-based device. It's really simple in the sense there's a track across the ceiling with a harness and then there's a rope. But the things that you can do with it, you saw that guy that was kicking the bolster. Tell me if you would ever do that with a patient if they weren't connected to something like that. No way. No way. It would be way too unsafe and poor judgment of any therapist that would do that unless they had like 30 therapists around that patient. But it's still, with that said, it's still a really, really important skill to train because it's going to happen anyway. They're going to lose their balance and they're going to slip and trip on black ice or on coming out of the tub. So let's train them now in rehab. So when that situation happens, they have that reactionary postural control to be able to combat that fall.
I love it. So that's everything we had for questions today. Thank you so much, Dave, for your time and your expertise. And now, for anyone interested in learning how Direct Supply can help you navigate these new technologies and products, stay tuned for a brief demonstration by our dedicated product consultant, Kelly Sullivan.
Hello, my name is Kelly Sullivan. I am a senior product consultant here at Direct Supply for our rehab category of products. Today we're going to be looking at a few products that fall under the Biodex line. One thing that I want to do is ensure that you have a full understanding of how each piece might plug in to the current program that you have. First, I would like to talk through a poster board that I have here that really defines the Biodex message and how they go about presenting their equipment. So we start off in the nucleus here with the why. Why is this person behaving the way they are? What is the condition then that we're going to be solving for? And these are the various different ways we're going to be doing so. So for instance, when we talk about practice and repetition, repeatable exercises, and also how that connects to intensity and increase and ramp up period, how that relates to muscle memory, how that's going to encourage neurological behavior and help with stability and gait. All of those pieces are going to fall within that solution mix. We also have here task-oriented training as part of that wheel in terms of that rehabilitation for the individual. That's going to be using all different sorts of muscle groups and ensuring that that individual is going to have a healthy outcome at the end of their treatment and their rehab. Then we move out to the outer edge of this wheel, and then we start looking at specific products that are going to be that solution. The what is going to solve for that condition that we're faced with here. So that is essentially what we're going to be focused in on here today. 3 pieces out of their portfolio will be addressed. They, of course, have more product than that really fall into a holistic solution for you, which we're more than happy to answer questions on after this product piece. The first product we're looking at today is the Biodex sit-to-stand trainer. It's a fantastic piece that is a great addition to any environment, whether that be a PT-driven environment or a wellness-driven environment. It really is going to allow for you to do some activity that is fully functional. When you think about what is the most useful daily activity, functional move for you on throughout life? Well, it's going to be a sit-to-stand, right? Think from the time you get up in the morning to the time you go to bed, if you were to tally how many times you get from a seated to standing position, it's quite a few, right? If you think about it. So someone who is highly debilitated or dependent that doesn't have the opportunity to do a sit-to-stand because of lack of muscle strength or postural strength, postural control, but really, really lacking any kind of mobility because of decreased muscle tone in their lower extremities. This is a fantastic piece that's going to allow for you to condition those lower extremity muscles to get you from that seated position up to a standing position safely, and incrementally give you the ability to do so in a safe way. So how I'm going to demonstrate this today is just, first of all, just point out a few things on the system itself. You have a seat here with a seat belt for added security for the resident if necessary. But I really want to point out here is that I can give you some weight assistance. So if I want to give you 50% body weight assistance, I just move this up and down quite easily to get to the poundage of assistance that I'm going to want to provide you with. And then in the back here, I have a wedge. The wedge works as a range limiter. So maybe from day 1, we flip that wedge down, and that gives you less distance to travel with that sit-to-stand activity. Day 1, I'm going to give you some additional weight assistance as well to make this activity more manageable. So come on in. We'll get you seated here. Go ahead and push back into that seat. There you go. I want you nice and flush against the seat. You look great. Hang on. Notice now how this area is nice and open. There's no pad, because a pad would mean that we have an obstruction in our natural ability to get from a seated to standing positioning. There are pieces out there that have some support in front of them. Now, it's not a biomechanical natural movement though to have something in front of your knees. It'd be like sitting in front of the wall there and then trying to get to a standing position as your knees hit the wall. Not easily done. So this is a nice wide open space. I can easily pivot you in and transfer you into the seat, and it's going to mirror a natural biomechanical movement. So go ahead, and we're going to go and stand up nice and slow. Good job. So we'd be doing whatever you would like to prescribe, whether that's a set of 2 sets of 10 or what have you. We'll have you sit back down. Progressively now, I'm going to change the weight that's on the system here. So let's have you stand up one more time, I'm sorry. We're going to change the weight now. We're going to offload it all the way back down to minimal weight assistance, and we're going to remove that range limiter. So go ahead and feel that difference. You're sitting much deeper into that sit. And now we're on day 10, day 12, what have you, and we've taken incremental weight away from that assistance. So now we're really focused on you using your own muscles to get you from that seated to standing position. But we've done this day in and day out. So now your muscle has increased tone and you're more comfortable with this movement. So go ahead and stand up again. You can feel that difference.
Yes.
So really easy piece to use. There's not a lot of complexities to it, and it's a nice small footprint, and it's going to be in a digestible price point for you as well. So I encourage you to take a look at this product for your community and your clinics. The next product we're looking at here is the Biodex Balance SD. It's an assessment tool that you can use in your clinic where it's going to allow for quantifiable, measurable data for you to assess that patient's baseline. Where are they at? What is their risk for falls right now as it pertains to their demographic information? With balance, we all know that that can change daily. So being able to have a timestamp and look into that change in behavior on a daily basis, weekly basis, and actually see what those finite data numbers are going to tell me, what that storyline is going to reveal, without just observable data is really important. I can print this information off, the reporting I can send off to a doctor. It's going to give me hard evidence on where that person was and how I progressively moved them to a more stabilized posture that's going to protect them from falls. So the first thing we're going to show is going to be on the screen here, the testing. So you have both training and testing available for use. If we go into the testing, you'll see there's 6 different tests that are available for me to choose from. Today, because we don't have time to get into all of the details of the product, I want to really focus in on one test called the CT-SIB. This is going to really work towards giving me information around proprioception and how they are spatially aware of their surroundings, their postural sway, their lateral control. You can see here on this screen, it's asking for a lot of information, demographic information. Really all we need is going to be date of birth. So here I would plug in the individual's date of birth. I would call out what gender they are, and then I would go in and address what height they are. And then next, I can go straight away into the training. And here, what I'll be looking at is the information that's gathered from the test itself. So you're not going to see the trace during the assessment. It's going to be a graphical image that I'll see thereafter the testing is complete in the results portion. All right, so I'm actually going to have I want your feet to be right across the center line here. So the arch of your feet should be across that medial line. There you go. Centralize yourself. This test just requires a static platform, but with the balance tool that you see before you here from Biodex, it does have the capability of doing dynamic testing and training as well, where I can change the movement of the platform underneath the resident to challenge them as they progress in their recovery. So we'll go into the testing. The first test, there's one of 4 here in this particular STSIB test. The first test is going to be eyes open. He's going to stabilize himself, hands at hip, if you can, and try to stay as stabilized as possible for those 30 seconds. The second test would then be, I'm going to take away one of his senses. I'll have him close his eyes for that 30 seconds and see how that changes his behavior a bit. Thirdly, we'll be putting this balance pad on the platform, which is going to be an unstable surface for him to stand on. Again, another level of challenge for him for his body to relate to. And then lastly, I will take away his eyesight and ask him to close his eyes with the unstable environment. So first off, we're just going to show what this looks like for the eyes open portion of the testing. So we'll go ahead and hit start. We'll ask the system to collect the data, which means for those 30 seconds, it's going to pull in information and give me that data set that I'm looking for in the results. So it counts it down, and here we go. We are in the testing mode right now. As you can see, again, there's no trace for him to visually see or biofeedback with this particular test, because we don't want him manipulating the test in any way, shape, or form. Biofeedback, though, I do want to say is an important component of some of the pieces that we're seeing today. In the next part of this demonstration with the practice portion of it, we'll look at how biofeedback is essential to self-correctment. All right, nice job. So we'll stop there. As I mentioned, there's 4 pieces to this particular assessment. I want to show what this looks like in terms of the results page. Once he completes all 4 tests, it's going to give me data information as to where he falls within that normative data set. So we can see by postural sway, which is a really strong indicator of what their potential risk for falls is, how much sway variance there is, and then here where they fall. Are they at high risk in the red, moderate risk in the yellow? Are they in the norm? Or are they doing better than the average person within that demographic? So it's really good, intelligent information that's going to allow for me to see where that person's baselined at and where they're going to hopefully be tomorrow after I've worked with them. Below here, I can even take a look at that tracing, that feedback that you would see on some of the trainers. But here as the clinician, I can see, okay, exactly what's happening on the platform. Where is that movement happening? Are there any major motions happening that's repetitive, that is maybe a clear sign as to a condition that might be at hand? Next, we're going to be looking at the training piece, which I push this here on the touch screen. You'll see that there's 6 core trainers that we can dive into. There's also some new games that they've built in that are fun and interactive for the individual to partake in when they're not being assessed. So this is another way to, from A to B, see how we can improve via the training possibilities here. For today, we're going to look at the postural stability option. Once again, I'm adding in that demographic information quickly, and that's going to give me my normative data and what I'm going to be compared to. So here I'm going to set up a couple targets. First, we're going to focus on lateral movement. So when I hit start here, you're going to be moving back and forth to hit those targets. There you go. There's a score, there's a time, so I could be using those as measurables and improvement. How long are they able to tolerate the activity, and what that score is and how that improves over time. Okay, great. Next, I'm going to establish a target for postural sway. And sorry, I'm a little off there, but we're going to go ahead and what you're going to be is moving front to back. There you go. I can give them a little encouragement here and help or guidance. I can even make it more difficult by changing from static to a more dynamic platform underneath him to be a little bit more challenging in the sense of the training itself. There you go. Great job. And then I'm tracking all of this information. I can save the results. I can print them so I can again show some of those big gains from day 1 to day 10, let's say. The last product we're going to talk to today is the Gait Trainer 3. Which also has a music therapy component that we'll be addressing as well. So here on the screen, you're going to see there's an option for a gait trainer and a treadmill. So you can use this product as a treadmill as well, but obviously the significance of the product really is in the gait training capabilities. So I'm going to once again enter in the demographic information to ensure that I am able to pull up that comparative analysis at the end for that results page. And then what I'm going to do is I'm going to look at what the goal is based on the information given to me. So based on the age I put in and all of the information presented, it's giving me a goal of 2.15 to 3.7 miles per hour as your gait. So we go into that. First we hit start, and then I'm going to ramp you up here. And you'll notice that there is biofeedback within this tool as well. And that's super important when we're talking about training, because it's going to give you information on how you're doing. So I'm going to hit begin gait training, and you can see your foot there. And if there's any information, so here we have some cueing. So it's going to tell you, if you were to have an imbalance in your right to left, it will say walk faster with your right foot to give you a verbal cueing, or to give you a cueing here. It also gives you that visual so you can self-correct. We also can graphically look at how you're doing left to right foot. If we want, we can add music to this as well. And the music component is a separate line item. But what's interesting about this piece of it is that I can select a song and I can look at beats per minute. And that's going to correlate with how fast, how many steps per minute. So he's stepping right now at about 85 steps per minute. So when I go into music, I want to find a song that kind of mimics that, close to it. So probably 80 to 90 is where I want him. And then the music's going to kick in slowly, and you're going to hear a metronome hitting so that it's going to give you some assistance in that mobility. What's great about this is when you're talking about a neuro patient, and we're looking at, ways that we can drive home muscle memory, neuroplasticity, ensuring that there is that cadence, that drive of cadence that is going to continue on thereafter the actual session, which there's actually clinical evidence that supports that claim. This music piece is one way that we can ensure that we can incorporate that muscle memory. So this is great, good job. When we end here, we're going to look at some results, the results page. So the system itself is capturing a lot of data. And the data is going to give me some clear insight as to where that person's at with their gait stride length, their cadence, the coefficient of variance between their right versus left foot, how much time they're spending on each foot. There's going to be some clear tells if the person just had a total hip or a knee. We're going to know that the distribution is going to be off, but we can then record over time how it evens out, and I can show whomever, a doctor or family or whomever I want to, how that happened over time by date stamp, by each results page that I send over. This is great information for you too, right? It's probably pretty encouraging to see progression, right, versus just being on a treadmill and walking and not knowing if you're doing anything or progressing in any way. So it's an excellent system. It really is going to be a huge addition to your clinical setting, in the sense it's going to give you reliable data to really support the claims around a healthy gait and balance, for that matter, as well. Now that you've had a chance to see a few of these pieces, I wanted to talk a little bit about their chain that they have here in their messaging. What they mean by this is really talking to the person that is the more debilitated resident that's going to require more assistance, that person that maybe sits for long periods of time or potentially doesn't even have the ability to get from a seated to standing position. So that's going to be where we focus in on the rise from a chair, that sit to stand motion. How do we do that? How do we get that person rehabbed to the point where they're actually able to do that independently? As we move through the train here in their rehabilitation journey, we're going to see then the next goal will be to stay balanced, to have strong stability, to be able to independently have the strength to have that foundational grounding underneath them. And that, as we know now, since we've seen the product, can be done in various ways, whether that be through assessment or through actual rehab activities such as gait training. And then lastly, the final goal, we want that person fully functional. We want them walking, we want them to be safe, and we want them to be independent. So really, at the end of the day, it's a chain of events. It involves more than just one solution piece. As we know in the rehab world, it's an and and an and and an and. And in order to understand that full journey, we need to figure out how we go from one end of the spectrum to the other end in a safe manner. So I hope today you learned a few things. Thank you.
That wraps up everything we have for you here today. Thank you for the great questions, and an extra big thanks to David Wilcox for his time. We want to send our thanks to everyone who joined us today, and if you have any questions about the items discussed, you can email us at webinars@directsupply.com.